Hi friends, I'm Dr. Jeevat Vam. Today I will discuss about abnormal vaginal bleeding and its management. Normal menstruation rhythm regular from 21 to 35 days, duration 3 to 7 days, amount between 30 to 50 ml, flow non-clotted fluid blood. Definitions: menorrhagia prolonged greater than 7 days and or heavy greater than 80 ml uterine bleeding occurring at regular intervals. Polymenorrhea an abnormally short interval less than 21 days between menses. Oligomenorrhea an abnormally long interval greater than 35 days between menses. Metorrhagia variable amounts of intermenstrual bleeding occurring at irregular but frequent intervals. Causes of vaginal bleeding: dysfunctional uterine bleeding, endocrinologic causes, organic causes, medical, clotting defect. Dysfunctional uterine bleeding definition: uterine bleeding in the absence of an organic disease. Incidence: 10 to 20%, usually at extremes of reproductive life. Causes of dysfunctional uterine bleeding: the diagnosis of dysfunctional uterine bleeding can be made after organic, systemic, iatrogenic causes have been ruled out. Diagnosis of exclusion and ovulatory dysfunctional uterine bleeding. Ovulatory dysfunctional uterine bleeding. In ovulatory dysfunctional uterine bleeding, the predominant type in reproductive age due to alteration in neuroendocrinologic function, characterized by continuous production of estradiol 17B without corpus lutein formation and progesterone release. Estrogens leads to continuous proliferation of the endometrium, which eventually leads to irregular, unpredictable bleeding. Ovulatory dysfunctional uterine bleeding. Incidence up to 10% of ovulatory women. Polymenorrhea is due to shortening of follicular phase, or luteal phase can be prolonged by a persistent corpus luteum. Diagnosis by exclusion, history, general examination, abdominal pelvic examination, investigations manually to exclude organic causes. Organic causes: reproductive tract disease, pregnancy-related conditions, uterine lesions, endometrial hyperplasia, fibroid, cervical lesion, postcoital bleeding, erosion, direct trauma. Iatrogenic causes include the intrauterine device, oral injectable steroids for contraception or hormone replacement, and tranquilizers or other psychotropic drugs. Oral contraceptives are often associated with irregular bleeding during the first 3 months of use. If doses are missed or the patient is a smoker, long-acting progesterone-only contraceptives, Depo-Provera, frequently cause irregular bleeding. Systematic disease: blood disorders such as von Willebrand disease and prothrombin deficiency may present with profuse vaginal bleeding during adolescence. Other disorders that produce platelet deficiency, leukemia, severe sepsis may also present as irregular bleeding. Hypothyroidism is frequently associated with menorrhagia and/or metorrhagia. Cirrhosis is associated with excessive bleeding secondary to the reduced capacity of the liver to metabolize estrogens. Diagnosis: patient age is the most important factor in the evaluation. Ruling out pregnancy-related complications in all women of reproductive age. A complete list of medications is essential to rule out their interference with normal menstruation. Non-gynecologic physical findings: thyromegaly, hepatomegaly may suggest the presence of systematic disorder. Genitourinary, urinary infection or genitointestinal hemorrhoids. Bleeding may also be mistakenly interpreted by the patient as vaginal bleeding. Pelvic examination may reveal an obvious structural abnormality, cervical polyp, but frequently additional evaluation is necessary. Measurement of serum hemoglobin concentration, iron levels, and ferritin levels is an objective measure of the quantity and duration of menstrual blood loss. Additional laboratory tests, TSH, coagulation profile may be indicated. To determine whether bleeding is an ovulatory or ovulatory, high progesterone levels during the luteal phase suggest that ovulation has occurred. Liver function test if a liver disorder is suspected. Endometrial biopsy or hysteroscopy. A cervical cancer screening test, PEP test, HPV test if results are out of date. Testing for Neisseria gonorrhea and chlamydia species if pelvic inflammatory disease or cervicitis is suspected. Transvaginal ultrasonography can detect structural abnormalities including polyps, fibroids, endometrial cancer, and areas of focal thickening in the endometrium. Aims of treatment: to find the cause of bleeding, to stop the bleeding, to replace the blood lost. General measures: if there's a vaginal coital tear, suture it in operation theater, and if there's inevitable or incomplete abortion, then there's a uterine evacuation. Medical treatment: non-steroidal anti-inflammatory drugs inhibit cyclooxygenase enzyme in the production of prostaglandins, reduces menstrual blood flow. Oral contraceptive pills, one of the most effective treatments available for both menorrhagia and dysmenorrhea. Antifibrinolytic agents prevent conversion of plasminogen into plasmin, which dissolve the fibrin clots occluding the blood vessels. Progestogens, northestrone, medroxyprogesterone acetate. Progesterone releasing devices produce marked reduction in menstrual blood loss up to 80%. Mechanism of action: mainly locally, leading to atrophic changes in endometrium with very minimal systematic effect. Pharmacological treatment of abnormal vaginal bleeding, dysfunctional uterine bleeding. Mild cases control bleeding with the tablet northestrone acetate, oral 5 mg each hourly for 10 to 12 days. Life-threatening bleeding, admit patient to hospital and resuscitate with IV fluids and possibly blood transfusion. Control bleeding with tablet estrogen, oral 1.25 to 2.5 mg daily for 10 to 12 days. When the bleeding is controlled, continue treatment with tablet northestrone, oral 5 mg each hourly for 10 to 12 days, or tablet medroxyprogesterone acetate, oral 5 mg 8 to 12 hourly for 10 to 12 days, or low-dose oral contraceptive pill for 3 to 6 cycles. If heavy menses return, the tablets can be continued for as long as necessary. Atrophic vaginitis responds to vaginal estrogen cream treatment such as conjugated estrogen cream. Surgical treatment: structural abnormalities frequently require surgery to alleviate symptoms. Dilation and curettage can be both diagnostic and therapeutic, especially for vaginal bleeding due to endometrial hyperplasia. Hysteroscopy is a surgery procedure that can be used to diagnose and treat abnormal uterine lesions. The uterine cavity is distended with fluid, allowed direct visualization of the abnormality, and use the hysteroscopic instruments. Endometrial ablation to remove or destroy the endometrium reduces the amount of cyclic blood loss. Hysterectomy is performed for women with structural lesions not amenable to conservative surgery, multiple large leiomyomas. It also can be indicated in women with persistent dysfunctional uterine bleeding, but only if medical therapy has failed.